Welcome to Migraine Again. I'm Paula Dumas, founder and editor of our online community, focused on helping migraine sufferers suffer less and live more. Most migraine patients desperately want the pain to stop, but kind of think migraines are just agonizing episodes that come and go and not really anything serious. But a recent research study published in the medical journal Neurology changed all that. Today's interview is about that study, which revealed that every untreated migraine attack is actually changing the structure of our brains. And for me, and maybe for you, it's a wake-up call to start treating migraines more aggressively. It's not just about taking a pain pill for the symptoms, but about a lifestyle of disease prevention. So we're fortunate to have one of the study's authors here with us today, Dr. Richard B. Lipton. As the director of the Montefiore Headache Center in New York City, Dr. Lipton is one of the leading authorities on headache and migraine in the world. The center he directs is internationally recognized for its research on and treatment of headaches. A prolific researcher and writer, Dr. Lipton has published 8 books on the subject for patients and healthcare professionals. Dr. Lipton serves on the Advisory Council of the International Headache Society and is a former president of the American Headache Society. Thank you for joining us, Dr. Lipton.
Thank you so much for your invitation.
So our Migraine Again audience was really intrigued by and a little bit alarmed by the implications of this research. When you initiated the research, your goal was to understand how the brain was affected by each migraine attack, looking at people who get migraine with aura and those who get classic migraines. Is that correct?
Well, so our goal was to really understand the brain correlates of migraine attacks, within individuals over time, yes.
Great. And did you find a difference between the two patient groups?
Yeah, so we do see that so our study in neurology was a meta-analysis, meaning we pooled results from many previous studies to try to get a systematic summary of what's known. And what we see is that people with migraine, particularly people who have migraine with aura, are prone to what are called deep white matter lesions, which are bright spots on MRI that appear in the white matter, the part of the brain that connects one brain region to another. We also found that there was an increased risk of stroke-like lesions in people who had migraine.
So that's serious. The initial report indicated that every single migraine attack is actually contributing to the early onset of cell death and brain tissue loss that usually happens with age. So if you're a migraine sufferer, does that mean that your brain is aging faster than your body?
Probably not, actually. I mean, so it is true that the more attacks of migraine with aura a person has, the more likely it is that there will be structural changes in the brain. But I don't think people should worry about every individual migraine attack that they have, although I do think that traditionally we've said the reason to prevent migraine attacks with daily medication is to prevent pain and prevent disability. The reason to treat acute attacks with medications is to treat pain and relieve disability. And now we can say, in addition to the immediate benefits that people get from treatment in the short term, there's at least a possibility that more effective treatment will also convey benefits on a longer-term basis.
Good. Okay. Well, a few of our readers were actually a little more concerned about this. They feel like there was some fear that was created by the research, that they need support and stress relief to better manage their migraines, not scary or stress-inducing reports. Any response to that?
Yeah, so my response is that the research is a little bit scary, but think about the way the world has changed over the last 20 years for cardiovascular disease. So saying that people who have high blood pressure or diabetes or high cholesterol are at increased risk for stroke and heart attack is scary if you have hypertension or diabetes or high cholesterol. But the reality is those are remediable risk factors. And the nature of the progress we've made is that first it was shown that high blood pressure, diabetes, and high cholesterol were risk factors for heart attack and stroke. And then we showed that better treatment of high blood pressure, diabetes, and cholesterol reduced the risk that those conditions carried. And at this point, the science has not yet been done that's showing better migraine therapy protects people against the structural changes that occur in the migraine brain. That isn't proven, but I think the risk will motivate research and ultimately give people better control over their health and over the long-term sequela of migraine if that's what they happen to have. So I consider it a positive step, and certainly, migraine is a risk factor. Migraine with aura in particular is a risk factor for stroke, just like hypertension, diabetes, and cholesterol are stroke risk factors. And the hope is that as we learn more, we'll be able to help people control their health better by protecting them from the consequences of whatever illnesses they happen to have.
Great. Well, we like to say the more you know, the healthier you'll be. And the more...
Certainly the more you know, the more informed you can be in the choices you make to promote your health.
Right. Well, one of our priorities at Migraine Again is to help migraine sufferers stay on top of relevant migraine research that's actionable for them. That is, it matters, and there's something that they should be doing differently because of it. So let's talk for a minute about what we should be doing differently. So should chronic migraine sufferers get a brain scan to see if their brain has been damaged by attacks?
So, the major clinical role of brain imaging for migraine is to identify or exclude other causes of recurrent headache. So, on occasion, migraine-like headaches can be produced by vascular malformations in the brain tumors, and other sorts of diseases that can be detected by MRI. If someone has the new onset of migraine, if someone's headache pattern is getting progressively worse, if someone had one kind of headache and now they have a completely new kind of headache, brain imaging may be worthwhile to identify or exclude causes of the new type of headache or the change in headache profile. For someone who's had a persistent, stable pattern of headache, I don't think repeating diagnostic imaging without a specific reason for doing so is worthwhile. I think it's better, particularly for people who have migraine with aura, to say, what can I do to control my headaches today? And at least my mindset about it is that better controlling your headaches today, you'll improve your life today and next week, and maybe on a longer term basis as well, because the reality is all the steps we would take to improve migraine management are steps everyone who's suffering from migraine should take, whether or not they have deep white matter lesions on an MRI.
Good, thank you. The summary of your research report said that migraine-induced volume loss is reversible with treatment. So what kind of treatments?
Yeah, so those are studies that show that people who have frequent migraine have demonstrated shrinkage of the brain in particular regions. And then when the migraine is treated with preventive medicines on a daily basis that reduce attack frequency, the shrinkage actually reverses. And that's really very encouraging because it suggests that at least part of the impact of migraine on the brain is reversible with effective treatment. So obviously I'm a clinician first and a researcher second. So I'm always most interested in things that will help patients with migraine.
Great. So let's talk about preventative treatments for a minute. You mentioned some of the preventative medications. I'd like to suggest some popular preventative treatments and then ask you to give me kind of a thumbs up or a thumbs down on how effective you believe it is in preventing migraine frequency or intensity. Okay, so yoga or Pilates?
So, so I think broadly, relaxation methods are an effective preventive strategy, particularly for people who have stress-related migraines. So I do yoga myself a few times a week and love it. And the stress reduction benefits of yoga or cognitive behavioral therapy or biofeedback may not only help prevent migraine, but help promote successful brain aging as well. So for yoga, cognitive behavioral therapy, and biofeedback, for all relaxation and stress management modalities, it's thumbs up, particularly in people who note that stress is a trigger factor. And I do want to say that we had a recent paper in Neurology showing that it's relaxation after stress that's the most prominent migraine trigger. So when you're really stressed out, preparing for the presentation, filing a brief, if you're a lawyer, writing a paper, or studying for an exam, if you're a college student, that's usually not when people get headaches. People usually get their headaches when they have a chance to relax afterwards. And of course, by practicing a stress management technique, that prevents the stress peak and then therefore prevents the decline in stress that becomes the headache trigger. So thumbs up for stress management, including yoga.
Good. I'd like to come back to that in just a minute. But keeping on our preventative treatments, what about eating clean?
So there are a number of dietary triggers for migraine. Some of them include food additives, and so nitrates and nitrites that are added as preservatives to food may trigger migraine. Bouncing blood sugars are migraine triggers for some people, so trying to eat foods that have a low glycemic index that don't dramatically raise blood sugar, and that includes chocolate, my favorite, and candy and other foods that have a high glycemic index. Avoiding those foods is useful. And then there are big individual differences in dietary triggers from person to person. So some people are sensitive to the artificial sweetener NutraSweet. Other people are sensitive to red wine. Many people actually are sensitive to red wine. Some people are sensitive not just to the sugar in chocolate, but to other chemical constituents in chocolate. And so my advice in terms of eating clean is that, everybody should eat a well-balanced diet, avoid food additives as much as possible, and probably eat a low glycemic index diet. And then above and beyond that, people should try to keep diaries to identify the trigger factors that are important to them. So if I'm sensitive to NutraSweet and you're not, I should avoid NutraSweet, but you don't need to, for example.
Makes sense. So thumbs up for eating clean. How about good hydration?
Good hydration is always important. Dehydration is a trigger for many people. There are lots of health benefits to good hydration. Probably the best thing to drink is water, and I think many of us don't drink enough. So thumbs up for hydration too.
Okay. High omega-3 diet or fish oil or krill oil?
Yeah, so I think high omega-3s are very healthy for a number of reasons. They may help raise good cholesterol. They reduce the risk of heart attack and stroke. And there's emerging evidence that they help in migraine prevention too. So I'm all for them, although I have to say the rigorous scientific evidence for omega-3s is not as strong as I wish it were for migraine, but there are many reasons to eat a diet rich in omega-3 fatty acids.
Can't go wrong. Okay, exercise, aside from yoga and Pilates, just other forms of exercise?
So physical exercise is great. It is effective as a treatment for depression, for anxiety. It's a stress reducer, and physical activity does appear not to decrease your chances of having migraine, but to decrease migraine frequency in people who are regular exercisers. So I'm all for that too.
Trying to find a thumbs down for you, but I'm only finding thumbs up. How about supplements like riboflavin, magnesium, melatonin, CoQ10?
Right. So your list is a good list. So the American Academy of Neurology recently published guidelines on drugs and natural products that were useful in migraine prevention. The only one that's in the same category of effectiveness as the best prescription drugs like topiramate and divalproex sodium is a supplement called Pentadolix. That's an extract of the butterbur plant. There have been a couple double-blind studies showing that it is effective in doses of 75 milligrams twice daily. I hate to plug a branded product, but if the extraction is not done right with butterbur, then there can be toxic alkaloids in it. So I recommend the Weber and Weber product to my patients. It's a German company. The German government actually regulates natural products. So I know what people are taking when they take the Weber and Weber product. Other products may be just as good, but I just don't have a good way of knowing. So B2 and magnesium are both in the second category of evidence for natural products in the AAN guidelines, as is magnesium. So B2 is something I recommend very often. I tell people it's the great free swing in migraine prevention, and by that I mean you take 200 milligrams twice a day. Effects develop over a couple of months. I don't expect to see benefits immediately, but it really is quite effective as a migraine prevention and preventive in double-blind studies. Melatonin has been shown to work in doses of 3 milligrams a day, although the best evidence wasn't available at the time the AAN wrote their guidelines, so it's in a it has a lower level of evidence because guidelines get out of date almost immediately as soon as they're written, and that's a good thing because it means we're making progress. Magnesium has a role as a migraine preventive. The only challenge with magnesium supplementation is that in some people it can cause cramps and diarrhea, but it's a useful preventive. CoQ10, there's limited evidence for CoQ10 and riboflavin work through similar mechanisms. I usually have people try riboflavin first because it's much less expensive and slightly better studied, but I think they're equally effective.
Great. So you mentioned butterbur, that it needs to be extracted properly to be effective. Feverfew?
Feverfew, the evidence is very mixed, and I'm not a big fan of feverfew based both on the very inconsistent results of studies and the fact that it may be difficult to get adequate concentrations of the active ingredients in feverfew extract. So it is helpful in some people. It has anti-inflammatory benefits. I'm certainly not opposed to it, but it is lower down on the list than the other natural products we've been talking about.
Good. So our thumb needs to be adjusted for different scales. Yeah. Okay. And how about essential oils?
Essential oils, I am neutral on. Can't hurt. The more omega-3s, the better. I like it.
Great. Massage therapy?
Well, I'm a big advocate of massage. I don't think insurance companies should reimburse for it, but I think, massages can help, particularly because, migraine pain is not caused by muscle tension, but massage can relieve muscle tension, and in people who have trigger points, massage can be helpful, and it's certainly a great relaxation method.
Can't be bad, just might not be as effective as other things. How about sex?
Sex? Well, I'm for it. I don't, so sex is interesting because some people have headaches that are triggered by sex, particularly by orgasm. And in a small subset of those people, headache triggered by sex may not be migraine at all, but might be a manifestation of the abnormal blood vessels in the brain. So if someone has the sudden onset of headache during sex, and particularly at the time of orgasm, that's a reason to see a doctor to make sure there's nothing else going on. And, 75% of the time nothing else is going on, but that's a symptom that deserves a workup. For people who find sex enjoyable and relaxing, which is almost everybody, thumbs up, though there's never been a randomized trial on frequency of sex as a migraine therapy that I'm aware of.
So sex gets either a thumbs up or a thumbs down.
Well, so orgasmic headache is get a workup. Sex is thumbs up.
How about good sleep hygiene?
So sleep is a migraine trigger. Many people who have migraine also have insomnia. Janetta Rains, who is a very well-known psychologist who's both a headache expert and a sleep expert, has done a small study showing that if you randomize people who have migraine and sleep disturbance to an intervention designed to improve sleep versus a control intervention that's sleep neutral, the people who get the sleep intervention have a decrease in headache frequency. So they sleep better and their headache frequency goes down. So it's a little embarrassing to give people medical advice like, manage your stress, manage your sleep, eat regular meals, eat clean. Those it's like do everything your mother told you to do when you were 14. It doesn't feel like profound medical advice, but those things are actually hugely helpful to people with migraine, because the hallmark of migraine is a nervous system that's sensitive to a wide range of trigger factors or provocative factors. And in a way, these sorts of interventions are managing hypoglycemia by eating regularly, managing inadequate rest and sleep deprivation by practicing good sleep hygiene, managing stress in whatever ways. All those things actually matter at the population level and may matter more for one person versus another. So it's important because you can't change everything in your life all at once, so it's important for people to choose those areas that are likely to be most helpful to them.
Right. Well, let's get back to some of the more medical options then, such as Botox or I don't know.
Onabotulinum toxin A. Yeah, so onabotulinum toxin A works for chronic migraine, but not for episodic migraine, where chronic migraine is defined by migraine with headache on 15 or more days per month. So if somebody's having 4 headache days per month, Botox is unlikely to work. They're also unlikely to want to get treated with Botox. But for that group of people who's having headaches on as many or more days than not, there are two very good double-blind randomized trials that show Botox works as a chronic migraine preventive, and in fact, it is the only drug that has FDA approval as a preventive treatment for chronic migraine.
Great. And recently, Cephaly introduced a headband, and there's been some electronic stimulation options. Do those work in the same way as Botox?
So there are two devices that are currently FDA approved. One of them is the Cephaly device, which is a form of transcutaneous electrical nerve stimulation. People apply an electrode to the forehead, then they slip on a device that has earpieces that fit on the ears, press a button, and stimulation begins. The device is approved as a migraine preventive. The idea is that people stimulate for 20 minutes a day, every day, whether or not they have headache, and the intent is to decrease headache frequency. There's a double-blind study that was published in Neurology that shows it works, and that was the basis of FDA approval. The device has essentially no risk, and in the people I've given it to, I've seen some people respond really well. Others find it difficult to tolerate. They find the stimulation painful, and still others have not really benefited. So it's certainly an option. I'm feeling a little disappointed with it at the moment, because it hasn't lived up to my expectations that were very high following FDA approval. Transcutaneous magnetic stimulation, TMS, is also FDA approved, but whereas the Cephaly device is approved for prevention, TMS is approved only for acute treatment and only for migraine with aura. So the migraine with aura is almost always visual and is generated in an area in the back of the brain called the occipital pole. The TMS device made by a company called eNeura, you apply to the back of the head when you have aura or headache. You push a button, it delivers a strong magnetic field, and in a double-blind study that I led, actually, it was shown to produce much higher pain-free rates with active treatment than with sham treatment. So I think TMS is a good option. At the moment, it's only available through a limited number of headache centers who are offering it for free to get more long-term experience with the device. So it's not commercially available yet, but it's available for free at a number of centers in New York, in Philadelphia, in Scottsdale, and in Los Angeles, among other places. Limited distribution. So we have it available. I mean, the good news is you're guaranteed active treatment, and you get it free. So and if it doesn't work and you don't like it, then you stop. So and the FDA has designated it essentially a no-risk device. So actually, both the Cephaly device and TMS are very, very safe, and that's one of the things I like about both of them. So there are other devices in development. There's a portable vagal nerve stimulator under study for both migraine and cluster. It's approved in Europe, and that is a device of some promise. There is an implantable device which requires a surgical procedure that's inserted into the sphenopalatine ganglion, which is a ganglion kind of at the back of the nose. And there's electrical stimulation of the sphenopalatine ganglion with that device. There's studies underway for occipital nerve stimulation as well. which also is an invasive treatment. These invasive treatments really are treatments for people who haven't responded to more conventional treatments. I mean, with the Cephala device, the TMS device, or the vagal nerve stimulator, it's a portable stimulator. You try it, there's no surgery and very, very little risk. For occipital nerve stimulation and sphenopalatine ganglion stimulation, that requires a surgical implantation, and although the risk is low, there's some risk of infection or migration of the device or other problems. So those invasive treatments are treatments of last resort, in my opinion. The non-invasive devices really have very favorable side effect profiles, great safety records, and and certainly work in some people. So it's easy to be in favor of that.
Good. How about migraine glasses?
Yeah, so migraine glasses are intended to filter the wavelengths of light that people with migraine are most sensitive to. So one of the common migraine defining symptoms is what doctors call photophobia, which is just defined either as excessive or heightened sensitivity to light, or sometimes as the triggering of headaches by exposure to light. So for people who are very light sensitive due to migraine, the glasses filter out the wavelengths of light that most cause photophobia, and they can certainly be helpful.
Great. And lastly, infusions?
Well, so infusions, it depends what you're infusing. So infusions are used both in outpatient infusion centers and in inpatient settings to break a cycle of intractable headaches. So the idea is that people with chronic migraine may get to the point where they're having headaches almost every day or every day. They may be taking medications to relieve pain on a daily basis. Sometimes those acute treatments work, but the headaches come back as the medicine wears off after a few hours. Sometimes acute treatments that had been effective stop working altogether. And when people are in that setting where they're overusing medications and have medication rebound, that's a real trap, because the only thing that makes you feel better is taking the drug. If you don't take the drug, you feel worse. If you take the drug, you get relief, and then when the drug wears off, that triggers your next headache. So you're both dampening the fire and feeding the fire with more drugs. And in that setting, intravenous infusions are sometimes, a life-changing option, because they help control headache pain while the overused medication is withdrawn and while effective preventive medication is established. So there are a range of intravenous infusions that are used inpatient and outpatient. Dihydroergotamine with an anti-nausea medication is probably still the most widely used intravenous infusion. Steroid drugs are sometimes used IV. Divalproex sodium, is sometimes used intravenously as well to relieve headache. Magnesium is sometimes given intravenously. In other countries, IV aspirin is used. In the US, it's unfortunately not yet available to the best of my knowledge. So IV therapies play a role either for breaking a cycle of intractable headache, or they play a role in the emergency department as well.
Right. Well, we're focusing just for a second on preventative treatments. And you did mention a number of preventative drugs. I'm not sure that it's worth going into each of those individually. We're really looking for anything else that you would give a thumbs up or maybe a thumbs down to, that you think people are wasting their money or their hope on.
So I think there are two major acute treatments that I give a thumbs down to. One of them is narcotics, opioid drugs, and the reason is not that I have a moral objective to opioids, because I don't have a moral objection to opioids. I just think on a long-term basis, they make people more sensitive to pain in a phenomenon that's called opioid-induced hyperalgesia, and on a long-term basis, they make headaches worse. And I would say the same thing for barbiturate-containing combination of ingredient products, so the Fiorinols and Fioricets of the world, which bear the name of the Montefiore Headache Center, so I hate to trash them, but they do make headaches worse on a long-term basis and are best either avoided or used with a tremendous amount of caution. On the preventive side, there are a lot of drugs that are used for preventives. There are actually only 4 drugs other than Botox that are FDA approved, and those are 2 drugs that were originally developed for epilepsy, divalproic sodium and topiramate, and 2 drugs that are beta blockers that were originally developed for hypertension or angina, and those are propranolol and metoprolol. In addition to those agents, we often use tricyclic antidepressants, which may be particularly effective in people who have frequent migraine with sleep disturbance. We sometimes use the calcium channel blocker verapamil, which has the great virtue of not having cognitive side effects, though it may be less effective than some of the other agents. And then we use a variety of other drugs that were developed either for epilepsy or for heart conditions. Sort of the good news on the prevention side is that there's a new class of preventive drugs being developed, which are called CGRP monoclonal antibodies. So a monoclonal antibody is an antibody that has a single target. CGRP, or calcitonin gene-related peptide, is a neurotransmitter, a molecule that nerve cells use to talk to each other, which plays a major role in migraine. So years ago, Peter Goadsby showed that if you measure the blood draining from the brains of migraine sufferers by drawing it from the jugular vein, during migraine attacks, CGRP goes up. If you give people a triptan, CGRP goes down as headaches improve. So we've known for a long time that CGRP was very important. These monoclonal antibodies bind CGRP. There are 4 companies developing antibodies that target CGRP. 2 of them thus far have publicly reported their results at the most recent American Academy of Neurology meeting, and the results look extremely promising. So everybody's really excited about this new class of preventive therapies, though it's probably still a few years away.
A few years away. We did a report on the CGRP drugs, and it wasn't clear how soon we might see those in the market, but clearly it's giving people hope. Your estimate would be a couple of years?
Yeah, well, so 2 of the drugs, for 2 of the agents, phase 2 studies are done. Launching and conducting a phase 3 program takes a year and a half. Then there's time for analysis, filing with the FDA, and the FDA can take up to a year to review a portfolio once a company submits it. So I don't think we're going to be able to give these drugs outside the context of clinical trials for 2 or 3 years, but they will be available in the context of clinical trials at research centers.
Great. So tell us a bit more about the additional studies that you have going and what you hope to learn from them.
Well, so I'm a neurologist, epidemiologist, which means that I'm interested in studying migraine in the population. So we have one large study called the American Migraine Prevalence and Prevention Study, where we screened 164,000 Americans selected to be representative of the population of the continental United States. And in that group, we identified more than 30,000 people with severe headache and selected a random sample of 24,000 of them and followed them annually for 5 years. And the purpose of the study really is to look at how patterns of treatment change, if diagnosis is stable, if people progress, if people remit, and what factors are predictive of prognosis and outcome in the sample. And we have a second study. So in that study, we follow people annually. We have a second study called CAMEO, which is the Chronic Migraine Epidemiology and Outcomes Study. In that study, we follow about 12,000 people with migraine, but we follow them much more closely every 3 months. Again, looking at how headache frequency, headache-related disability, comorbidities, patterns of treatment change, but this time over 3-month intervals over the course of 15 months. And so we've learned a lot from these studies. I mean, one of the most important things we've learned is that of people who have episodic migraine, which is almost everyone with migraine, and episodic migraine is defined simply as migraine with less than 15 headache days a month. Among people with episodic migraine, about 2.5% of people a year go on to develop chronic migraine, the severely disabling form of migraine, where people have headaches more days than not. And we've done a lot of work trying to identify risk factors that distinguish people with episodic migraine who progress to chronic migraine from people with episodic migraine who continue to have stable disease from year to year. And so not surprisingly, among people with episodic migraine, the worse you are, the more likely you are to continue to progress. So high frequency and high disability are important predictors of progression. We've also shown that depression and anxiety are associated with more severe outcomes, that comorbid conditions like asthma and rhinitis are associated with more severe outcomes. We've shown that early childhood stressors, adverse childhood experiences are associated with more severe disease. We've shown that life events that are stressful in adult life are associated with disease progression as well. We've shown that use of opioids and barbiturates, the drugs that I gave the thumbs down to, are actually associated, if you use them, with an increased risk of getting worse over time. And so that data is part of the reason that I think opioids and barbiturates are, for most patients, a bad idea. We've shown that poor optimization of acute treatment, so in other words, if when you take your migraine medication you have prolonged, persistent pain, we've shown that that's associated with an increased risk of progression, that a phenomenon called allodynia, which is the experience of ordinarily non-painful stimuli as painful, are associated with progression as well, and that obesity, which is a pro-inflammatory state, is associated with progression. So we've identified a bunch of risk factors. And with respect to migraine progression, again, to go back to that analogy that I overuse for cardiovascular risk reduction, I feel like in preventing chronic migraine onset, we are where the cardiologists and stroke specialists were 10, 15 years ago. So we know a lot of risk factors. We know they're associated with progression. For many of them, we know that they have a dose-dependent effect, meaning the more depressed you are, the more likely you are to progress. The more opioids you take, the more likely you are to progress after adjusting for other factors. But we have not yet done the intervention studies where we show if we identify people at high risk and we intervene to reduce their risk, that we can prevent the new onset of chronic migraine. And I think that's the crucial next step in terms of my research And I believe it's a crucial next step for the field as well.
Right, so you've identified a number of the watch-out factors. The only question is, if somebody addresses the watch-out factors, will they be able to prevent it, or is it inevitable?
Right, yes, right. And I would say we need to do the studies on the one hand. On the other hand, if someone has migraine and depression, treating depression is a good idea. If somebody has migraine and high levels of stress management is a good idea. If somebody has migraine and obesity, weight loss is a good idea. We actually have a randomized trial in the field looking at behavioral weight loss interventions in people with migraine, and that study is led by my collaborator Dale Bond, who is at Brown. So that's the intervention study that we were able to get funded, and we're working on launching other sorts of intervention studies as well.
Terrific. We appreciate you doing that, because I'm sure we're going to learn something from it.
I am very excited to do it.
So let's talk about the Montefiore Headache Center. What kind of inpatient treatment and clinical trial options are available to migraine sufferers through your center?
So we have 7 neurologists who see headache patients. We have 2 health psychologists who do behavioral interventions and biofeedback. And we offer a pretty broad range of services. I mean, the most important thing in headache management is actually getting the diagnosis right. And so we, because like all tertiary referral centers, we tend to see people who have been treated in other places and not done well. And the truth is, the easiest thing to fix is the diagnosis was wrong. Because like other areas of medicine, headache diagnosis and headache therapy are intimately linked. And so if you get the diagnosis wrong, you're going to get the treatment wrong. One of the other things we find very commonly is that there are important trigger factors that initiate headache that have gone unaddressed. And probably the most common thing is, if someone's overusing barbiturates and opioids, it's hard to make them better, no matter what else you do. So we find that's quite important as well. We find helping people understand their disorder and teaching people to manage their disorder is really important. So people in medicine often say, the doctor manages the patient. But that isn't really true, because if you have a migraine, you're at home, I'm not there, you're going to have to decide how to treat it. And it was up to you in the days running up to your migraine what steps you took to reduce your chances of getting a headache as well. So I don't think it's really true that physicians manage disease, certainly not chronic illnesses like migraine. I think patients manage illnesses, and it's the job of the care delivery team to give patients the tools they need to manage their medical disorder and manage their lives in a way that optimizes quality of life and minimizes disease burden. So we very much take an interdisciplinary approach. At any given time, we've got multiple clinical trials going. So at the moment, we're doing one study on an over-the-counter acute migraine medication. We're doing a study on transcutaneous magnetic stimulation. We're doing a study on vagal nerve stimulation. We're doing a couple of studies of sphenopalatine ganglion stimulation. We're doing a follow-up study on onabotulinum toxin A. We're doing a study of a couple of the CGRP antibodies that are under development. So we have a number, so we have a number of different studies going. Of course, our main objective for the patients we treat is to help the patient with their disease. And most people who come to our center do not participate in clinical trials. Many people do, and there are many advantages to participating in clinical trials, not the least of which is, we can't do what works until we figure out what works. And I feel like our center and our doctors are kept up to date, and we get better at our clinical jobs by spending a lot of time on sort of the leading edge of where treatment is moving. So I love that we do research. We also do a lot of education. So this year we have 3 fellows. So our fellows are fully trained neurologists who want to specialize in headache medicine. And so they participate both in our clinical work, in our clinical research programs, and they're a huge asset. First of all, because there's nothing like teaching to help you discover gaps in your own thinking and knowledge that you didn't notice until you tried to explain it to someone else. And second of all, like whenever a fellow says to me, I have to ask a stupid question, I think, oh good, I'm going to learn something. Because the reality is, when you're in a field for a long time, there's certain assumptions that you make, and the assumptions that are pervasive in the field become invisible, and someone new to the field can see things that are very difficult to see if you're immersed. So, so the educational part of what we do, because there's a shortage of headache specialists, is both a valuable service and, sort of leveraged, but also I think it helps all of us do our jobs better, because teaching is learning, and getting fresh perspectives is the way to stay sharp. So yeah, so I feel very blessed in my professional life.
That's great. Well, I think a lesser degree of that is true online, where people who are coming to migraine websites like ours are actually teaching each other. The challenge is kind of keeping the mistruths out of the conversation, or having people correct those who might be offering things that are giving people false hope. So we always advocate that people get themselves to a headache specialist, not just a generalist. And of course, the ideal situation is if they have the time and are able to get to a headache center like yours, where they have the benefit of the research and the expertise that you all bring to the table. So
my feeling is that most people with migraine don't need to see a headache specialist. I mean, I think probably most of the people who log on to your website have migraine as a priority in their lives and a burden in their lives, and there's a very good chance that the people you reach need to see a headache specialist. But listen, there are 36 million Americans who have migraine. There aren't enough headache specialists to treat them all, and so we have a big interest in educating general neurologists and primary care doctors as well. And just like if you have mild asthma, your primary care doc can do a bang-up job. If you have severe asthma, you should probably see a pulmonary specialist. And if your asthma is wrecking your life, you should see an asthma specialist. So I think the same is true for migraine. So I'm not, I certainly don't advocate that everyone with migraine should see people who are headache specialists. I think a lot of migraine can be very well managed by well-informed and motivated primary care doctors or general neurologists. And certainly a lot of my colleagues, do a great job.
that's a good point. Thank you for that clarification. We do reach people all over the world, in at least a dozen English-speaking countries. And many of them don't have access to the same kind of health care that we do here in the States. So for that reason, too, we feel like being able to share the information across the internet helps them to get the kind of care that they need. So thank you so much for your time and for your expertise. We genuinely appreciate your work. Migraine research is so important to helping us get closer to a cure for this disease. If you have any questions about what you've heard today, please send them to us at editor@migraineagain.com. And thank you for watching. We'll see you again soon on Migraine Again.